okay, I tell where have I been all these years? Like, how do these people know all these things? They're geniuses. I gotta back up. Okay, I'm gonna come back to that. I know I gotta go around. When I was at the Eldoa course, which was in Dallas, Guy brought somebody up to teach one of those exercises. Yeah, I didn't talk. Yeah, okay. So he brings this guy up to teach the exercise. They pick a student, and he goes, okay, go ahead and teach. It was one of the lumbar Eldoa. There's one for every joint of the body. It was like day one. So the guy sits him down. He goes, okay, go ahead and sit down. I want you to find the centers of your ischium, rock back and forth. I want you to bend your right knee. I want you to push down through the first meta. I want you to push down through your cuboid. I want you to go ahead and push down through your calcaneus. I want internal rotation at the knee. I need an out flare at the hip. Now he's teaching this guy. He's going out flare at the hip, and he normally wouldn't talk like this, but he wanted to talk through it for the 100 people that were watching. Out flare at the hip, decoaptation at the coxofemoral joint. Okay, you're going to find axial extension, meaning straighten out the spine. He pushes on the head. He tucks the chin. He has eyes 10 feet forward. He says external rotation of the arm, extension of the wrist. I want you to push out, decoaptate the shoulder joint, and then he fixes his shoulder height. Then he says push away from here, go here. I want you to internally rotate here, more here. So after I watched this guy teach one exercise, I walked up and I nudged the guy next to me. I said, "You know that guy?" And he goes, "Yeah." I said, "What is he like?" I'm thinking, he's like master PT guy or something like that, And he's like, "Oh, he's an athletic trainer." I was like, "Oh, I'm dead." Like I forgot all this stuff 14 years ago, but it was the coolest thing to watch him know exactly what each part should do to create tension in the fascial system to correct the spine. And I'm thinking that all these worlds are opening up for me at this seminar. I'm like, and just how far behind I am. So so anyway, that inspired me in and of itself. So then I go to Montreal. Guy's talking about all these lesions. It takes me till about the third 40-hour course before I even start to understand the lesions and the biomechanics and the compensations of the pelvis. He had an assistant at the course, which I would call every week, and he would go through this with me, and he's like, I'm thinking, I'm the dumbest person in the world. I'm like, I can't figure this out. He's like, if this happens here, this goes here, if this comes anterior, inferior, this has to go this way, and this has to go that way. It's relative. So I would draw it up on this whiteboard. I would fill the whiteboard up with biomechanics and just never get it, and erase it, and erase it, and erase it. And finally, it clicked. And I go to the third course. No, it's probably the fourth course at this point. And so he's asking the initial questions on the first day, and nobody's answering the biomechanical questions about the pelvis. If there's a lesion here, what happens here? And I would answer it. Because I would ask the stupid questions. When you're in the class and you don't want to ask the dumb question because you think it's dumb. I just ask it because I think everybody else is going to have the same question. In this course, they didn't. I was the slow person. So, but on the third one, he would ask, and then they wouldn't answer, and then he would look at me, and I would answer. And then it happened over and over again. He said, "Oh, he got it now. He got it." So I had it better than them. Come to find out, the people in this course, okay, Dan, the PT, worked 3 years later. He was Tiger Woods' trainer and worked with him for 2 years before he won the Masters that last time, after he had his back surgeries and those things. So he was one of Guy's proteges that was in this class with me that I'm working with. One of the guys is the chiropractor for the Carolina Panthers, who is a good friend of mine now, who's great. It's just super knowledgeable. Write something down. There's something on Instagram, and he's got a Patreon. It's called Anatomy Links. It basically looks at the body through the fascial tensegrity model, which we're going to talk about in 2 seconds. Let me get a time orientation here.
10 o'clock.
What time?
10 o'clock.
10, perfect. Okay, good. Because we're going to do 40 minutes here, 10 minutes of treatment, 10 minutes of questions, and then if you want to stay for the last 15, if you have any specific chiropractic questions, feel free to stay, but you're good to go after 60. So, where was I?
Tiger Woods, Masters.
Yes, Tiger's Masters.
Carolina Panthers.
Carolina Panthers
And
chiropractor who's awesome. When he comes in town to beat the Saints, which they usually do, we hang out. Another guy was the big hockey guy in the West Coast. Another guy was a Canadian chiropractor for some of the, I forgot who the big hockey names are because we don't follow hockey down here. But he was a concussion specialist. I didn't realize the level of student in that class, right, when I walked in the first day. But by that 200th hour, started to scratch the surface on, okay, there's a lot more to the human body than we've ever been taught. So after the 200 hours, I said, hey, can you just go through like how you do a treatment with somebody? Because we've learned all the assessments for the pelvis, we've learned all the orthopedic tests. Can you show me like, okay, if you find this, you go and you do this and you do that? And he said, no. Like, why not? Well, because that's not how things work. It's, you know, the complexity model. If you feel this, you've got to check this, and it could be this, it could be this, or it could be that, and then you're going to do. I'm like, well, show us that. He's like, no, I will not. We will not do that, because then you will put it in a box and you will think it's a system. And I'm like, so I was mad. And it wasn't until 5 years later of studying with Guy that I got it. I was treating a patient one day, and I realized, you know, there is no formula for anything. You really just, after you understand the three-dimensional anatomy of the body, which way all the muscles go, how everything connects together through the fascial system, how it's affected through the receptors of the nervous system, and your hands confirm what you feel. For instance, and I'll show you in a second on David, we do an assessment for the pelvis that's standing that feels the motion at the sacroiliac joints. Okay, so gravity pushes down through the head and the spine, and then the ground forces come up through the feet, through the coxofemoral joint. And there's a balance between gravity and the floor, and it's balanced through the sacroiliac joints. So these are the two most important joints in the body next to the craniocervical junction, which is which my mom's brother had injured, because this is the neurological center here where the brainstem enters into the spinal canal. This is where that affects your heart rate, breathing, most of your autonomic functions. But structurally, the SI joints and the iliums balance everything, the tension between gravity and the ground. And of course, all the reproductive organs are here. So if you have a problem here and tension here, it can affect the whole future of the human race if your organs aren't supported throughout your lifetime through a properly balanced pelvis. So structure of this is key. And what I'll do for the assessment is, and what we learned through E is, you know, you feel the motion and you feel it in the way that you would walk. So you bend the right knee, you bend the left knee. You go through positive torsion, you go through negative torsion, positive, negative, and you feel the SI joint. Well, for the first 10,000 times that I felt this, I couldn't feel anything. Like, he's got to be crazy. Like, this thing just doesn't move. But I just kept doing it, kept feeling. Eventually, I said, oh, I feel movement. And then I said, oh, I feel that that's supposed to open there. And then I went back and reviewed my notes and said, okay, this is what's supposed to happen here. And then over time, years and thousands of attempts, I can feel what the SI joint is supposed to do, and when there's a lesion or a restriction, and where it could be coming from. And then what we do through chiropractic is we adjust that to remove the restriction. But there's all types of techniques. In PT, they may do some muscle energy technique to open it up. Or somebody might do some myofascial stretching if the ilium is anterior to pull it back. Like, there's lots of ways to treat the body. Like you were saying, we see things differently sometimes, but there's a lot of ways to access all of these things. And you know, Guy taught us how to treat the ligaments and the fascia and the tendons. And you know, the foot, you know how many ligaments there are in the foot? That's why I said I don't like the foot. There's too many ligaments, too many things that need to be treated, too many things that can get hurt. It's too difficult. But this is what we mastered with chiropractic, these two, and of course the rib cage. And you'll see what I do when I adjust David there. And we're talking about chiropractic school. First day in chiropractic school, you go, and you'll do this in PT, I'm sure too, is feeling and palpating. You know, first you learn all your landmarks, and then you go and feel how do things move. This bone right here is called the atlas. It surrounds the brainstem. And there's two little parts that come out right here. They're called the transverse process. And you have different muscles that connect here into the scapula, come down to the trap, the later scapula, all these different things. Well, in chiropractic, the first thing you do is you learn to feel the position of this bone, and then you feel this muscle to see if it's tight. Could the bone be out of alignment? Is there head tilt, and different postural assessments? So you get an impalpation class, somebody sits down in front of you, and you're supposed to feel this bone. So you come from the behind, you come under the mastoid, and you're supposed to feel this bone. I feel it, I'm like, all I feel is skin. I don't feel anything. But everybody else in class, oh yeah, I feel that. Garbage. It took months to be able to feel what the bone, just to feel the bones, to feel that there's something underneath all this skin, right? Then what you have to do is learn, how does each bone move in relationship to the other bone? How does it, when is it not moving properly? And then how do you correct it with a force to put it back into the proper position so that you can take pressure off the spinal cord and off the nerves that control the organs of the body? So you go way back to the beginning, you've got to be able to feel. You've got to know the anatomy. You have to know the biomechanics. And then you have to be able to do a treatment on a human body that, everybody's different. Your tissue is different than your tissue, different than your tissue. Knees move a little bit differently. People that have, you've got people that have different conditions like Ehlers-Danlos, where they're hyper flexible, that an adjustment would be different on. You would do PT differently on them because you would want to do more strengthening. Knowing all these things allows you to be more accurate in your diagnosis, prognosis, and your eventual treatment plan. So no matter what you're going into, athletic training, PT, OT, chiro, osteopath, even some MDs are starting to understand structure. You've got to be able to feel. You've got to be able to know that everybody's different. And how do you apply your craft, whatever that is, to the level of a Guy Voyer, who's like the top of the top? How do you aspire to get to the top of the top? Because what they're going to teach you in school, what you're going to graduate professional school knowing, is what not to do and a little bit about what to do. And it's going to be up to you for the next 30 years. Hopefully you love what you do, because in 30 years of studying more and more to get a little bit more, so that when you take an assessment and you see somebody, you go, oh, their shoulders high on the right, they've got an anteverted scapula, their clavicle is medial, the internal rotation of the humerus, they've got left lateral flexion of the skull, right rotation of the skull, an outflare of the left ilium, a restriction at the greater arm of the left apex of the SI joint, internal rotation of the knee, pronation of the foot, and where's the primary lesion? Where's it coming from? Where's the problem? Because you can have a foot problem that affects your opposite SI joint, that affects your opposite shoulder, because of the fascial connections between all those things. So once you see the body globally as a system that's connected completely, and you learn an assessment that's not an A plus B equals C, and you can put your hands on somebody and diagnose and know where they're at and what you can do to help them, and then teach them the things they can do on their own to bring their spinal balance back into place, or help with their knee function or their ankle, then you're a health professional. Then you know how to help people get to the level that they want to be at. So I want to show you what that looks like. Oh, I'm going to show you the tensegrity stuff. It's okay, we're too long. See, when I was talking about what to go through with y'all, I was 2 hours in my brain, and I said, okay, that's not going to work. So I backed up, and then I saw something on the internet 2 days ago which made me think about something else. Have you ever seen anything on there where they punch into that fluid and it stops his fist? You seen this? Okay, 2 seconds with this. So that's called non-Newtonian physics. So when you learn biomechanics in school, you're going to learn the Newtonian way, right? Which means pullers and levies, an equal and opposite reaction to every force. The body does not follow those principles, okay? The body follows what's called tensegrity or biotensegrity. Tensegrity is triangles or tetrahedrons that if you move one of them, they all move. So if you look at, there's a great book, Buckminster Fuller in the 1800s came up with tensegrity. That's how they build bridges. It basically, what it means is you've got these rods, which are compression, and you have these tension elements. So it's tension and compression. You can see none of those rods touch each other. And if I pull on one side or push on one side, you get a deformation of the entire structure. Well, that's how the entire body's set up. Between the way the vertebrae are, they're all triangles, between all the ligament structure, and especially all the fascia, which connects all the distal body parts together. So if I affect the fascia in the gastroc, it's going to pull up to the medial hamstring, which is going to the sacrotuberous ligament, which is going to go to the lumbosacral fascia, which is going to go into the underneath the scapula here, which will pull on the opposite side of the neck. Everything's connected in that way. So this biotensegrity, this non-Newtonian physics, is this. It's I think they made it out of like cornstarch and water, right? The faster you push into it, the more force it gives back. Well, the body being a fluid structure, the compression element is not the bones. It's the fluid, because fluid's non-compressible. So as you push into the body, it starts to give you more force back, but it's not a Newtonian force, so it's completely different. So your palpation skills go from, oh, this is a lever that does this, to, no, this is a fluid dynamic system that your ankle, how would you heal that ankle faster? You would pump the fluids in a specific way so that the white blood cells get there faster, so that you go through the inflammatory healing process in a faster way, so that it heals stronger. And then you do proprioceptive exercises, and there's just so many things to do on top of our RICE standard that we give, right? Because it's a fluid dynamic system, and then you could adjust the joint at the end to make sure everything's back in its proper place after internally rotating and rolling it on the outside. So you put the joints back into alignment after the fluid has been moved around. So anyway, that's a long thing just to say, look, the body is not set up the way that you're going to learn in school, and you'll never learn the next level, which is this biotensegrity system, unless you go out and search for it. But it's so valuable if you want to know how to actually look at the body and treat it correctly. So when I'm feeling the pelvis, come on out here, David. So I'm just going to adjust him. And the reason I want to do an adjustment is this. Everybody seen an adjustment on YouTube? Okay. When I first started to watch these YouTube adjustments, I was horrified because they sucked. And, they were terrible. The people, usually the delivery was poor, there was no analysis, and they were just moving every bone that they could. And I thought, this is what the public is going to think chiropractic is. You just throw somebody on a table and you start moving things around, and they're pulling on the neck and they're doing all these things. And I'm like, this is bad for chiropractic, And then people would start coming in saying, I saw this thing on the internet and I need that. I'm like, mind blown, wrong most of the time. So it ended up being good, but I still watch these things going, okay, like, elbows out, what are you doing? That's not the way the SI joint goes. Of course, that's what you do when you're in the profession that you're watching somebody do something with. So realize there's a lot that goes in before they put a force into the spine, hopefully. So when a patient comes in, let's say David comes in, not for your adjustment, David, just when you come in, we sit down with them and we talk about what brought you in. Now, typically for chiropractic, it's typically back and neck pain, because that's what people understand chiropractic is. It helps me with pain. They have no understanding that it helps with organ function or fertility or immune function or the way that your frontal lobe works to decrease the stress and anxiety in your life. They say, no, it hurts in my back, and they point here. So we find out what their goals are, we do a consultation, we kind of know what they're struggling with, but now we need to look at the whole system, right? Did you have an ankle injury 16 years ago that affected your SI joint, that affected your shoulder? We do a full health history. Then we do an examination. So they stand up, we check their posture, boom, left, right high shoulder, we check their pelvis, we look at their feet. We do an orthopedic and neurological test to make sure that they don't have any red flags. We have disc bulges, herniations, no weakness. We do muscle testing, make sure that not getting atrophy. We test all the different nerves to make sure that they're intact. If all those things are good, dermatome, sensory function, then we're gonna sit them down and we're gonna move their spine in each motion. We're gonna check their range of motion. We're gonna palpate their spine. We're gonna check the motion of their pelvis, since this is where everything goes to. So I feel the SI joints. Tell David to bend his right knee. Come on up, that moves normal. Bend the left knee. Come on up, there's more of a restriction on the left side. I tell him to step forward. I move my fingers so I can feel the motion of the sacrum. He bends the right knee. It moves normally, he comes up. Nope, stay there. Bend the left knee. So now I'm feeling for the sacrum to come back on the left side. It does not. He steps back on the right, forward on the left. So I'm feeling, bend the left knee. Come on up, that doesn't move. Bend the right knee, come on up, that moves normally. Step back, turn your toes out to the outside wall. Good, I'm feeling, again, the SI joint, but the different arms of it. Bend your right knee, come on up. Bend your left knee, come on up. And he doesn't move the top part of the left SI joint, okay? Now I've been adjusting David for a while, so I already knew that that's probably gonna be his pattern. It hadn't been adjusted in a little while. So we'll adjust that left SI joint. And then when David started as a patient, he had a T4, T5 rib articulation to the thoracic spine. That was out about this far. Like anybody could have felt this and felt that he had a problem there. But what did you feel? What did you think? Did you know?
No, it was like a pinching, stabbing.
And how long did you have that?
A good while, like a few years.
A few years, okay? So, and you just feel like, okay, that joint's out of place. And then if, and I'll put him on his back to feel his neck, but his C2 on the right is rotated back on that side. So we'll come out this way a little bit. So my point here is when you see the YouTube adjustments, there's a full assessment, hopefully that's been done before that, to make sure that the adjustment's safe for the patient. And then hopefully they're specific adjusters, meaning they're adjusting the bones or they're not adjusting the bones, you're adjusting joints that are stuck or restricted, and they're adjusting in the proper motion to bring it back into the right position, okay? A lot of YouTube stuff is just push on the spine and make noise. Totally different. The noise makes no difference. So he will go on your right side, which way? Here, let's turn this table around so I can see. Hang on one second. What time is it, John?
10:15. You got him for 30 more minutes.
Good, we'll do 15, let everybody go, who doesn't want to talk about chiropractic, and we'll be good. Okay. Right, yeah, left SI joint, so yes, on your side. Now, if I were to do this adjustment 100 times, you would see exactly the same thing. But on 100 different people, I'm adjusting a different part of this joint right here in a different way. You just wouldn't know any difference from watching it. So we put him into a position where his spine's completely straight. There's gentle tension to open up that part of his SI joint. Now, if you look at the SI joint, sacroiliac joint, it looks like you know, there's a top part and a bottom part, and they both are different. And if we're going to adjust this part, we need to adjust it this way. If we adjust the bottom part, we need to adjust it this way. If it's forward, we need to adjust it back. If it's back, we need to adjust it forward. If it's down on this side, we need to adjust it up on that side. That's part of the analysis. We take, oh, I forgot the part, we take x-rays after the examination. We correlate the x-rays to the examination that we did, and then we develop a treatment plan to correct those misalignments. That's what chiropractors do, just in case you didn't know. Now, the reason we do it is not because David has pain. Even though I want his pain to go away, I want to make sure his spine is as healthy and mobile as possible in those restricted spots so that his brain can send the proper bioelectrical energy to the organs to make sure that they work the way they were designed to work. That's the whole reason to be adjusted and for chiropractic care. And that objective can be different professions too. That's what we do. So I'm feeling the top part, right? So here's the PSIS. For those of you that have done all your palpation classes, learning where everything is, PSIS, posterior, superior iliac spine. Here's S2, which is the horizontal axes that the sacroiliac joint moves around in an oblique axis. I'm going to come just a little bit above it for the lesser arm. I'm going to contact there. I'm going to bring him over, and then I'm going to adjust through that joint that way to open that up right there. So then he'll go on his back. No, he'll face down actually. Sorry.
So Dr. Jeff, when you had him sidelined, you had to make sure his cervical area stayed in alignment too. That's why you had the
Yes,
headrest
try to
up.
keep everything as neutral as possible. Harder on a
Travel
travel table, but
Mm-hmm.
yes. Some chiropractors check balance of the feet, he's left short. Some people have anatomical differences in their bones that you've got to take into account. Some people need lifts. You can check the pelvis. You can see his pelvis even after the adjustment. He's rotated back on this side some. We can check his lumbar spine in rotation. And this is just a tonal palpation. Then we'll check the paraspinal muscles. You actually feel better today than usual, sir.
So you're testing right there, just the muscles are real active, which
Looking
can.
for, so any tight and taut trigger points. I'm feeling for any muscle spasms. I'm feeling for how each bone moves at the articulation. So for him, I know through adjusting him for a while, and even at the beginning, it's this T4-5 rib that comes around that articulates with, there's two articulations to the transverse, there's one to the transverse and one to the body of the thoracic spine. And for him, he had both of those misaligned. So if you look at the way the rib comes around, one articulation is here at the transverse process, which is part of the bone that sticks out here, and then the other part attaches to the body. So you actually have two joints that connect the rib to the vertebra. Some people have one that gets restricted, some get two. Ribs that are out of alignment are extremely painful. So when people come in with a rib that misaligned, 6'7" football player, almost crying over it, you can put that bone back in and they will get up off the table and be like, what the heck happened? What did you just do? It's one of the most satisfying things to adjust because it's so immediate. And he did well in a quick fashion also. So there's the spot there. And for David, I know it's kind of hard to adjust this one with him face down. I'm gonna do it, but I might flip him over afterwards, but let's just, so we would go here right on that joint. He's gonna take a deep breath all the way out. And then I'm gonna come straight down through that joint since it's both of them, and it actually already moves, so on your back. And then let's flip this around one more time. Since we got that there. And then we'll check his cervical spine.
And the other thing to be cognizant of too, guys, is that look how low his table is, right? He's using his body's momentum and body force. He's not exerting a ton of force, you know, he's using the ergonomics, right? So it doesn't matter that your size, right? If you put them in the right spot, you can easily do this kind of work.
For the last 4 years, the thing I've been studying the most is the most efficient leverage to adjust the spine, because I hurt my shoulder a couple years ago in the gym, but it was really just from adjusting with poor form for 15, 16, 17 years. So I've had to readapt some of my body positions, adjusting, because we'll adjust, you know, might adjust 50 to 100 people a day. So your body can wear out very fast. So I'm gonna adjust his left C5 here. So what we do is, I'll bring him over, I'm gonna contact above that vertebra and bring him over. And then we'll flex over the contact there, and then we're gonna bring that down through that facet joint here, that way. And although that looks like it might cause discomfort, it's about the easiest thing that you'll feel. It does, you know, as the bones move, now his range of motion comes back, and that nerve can start to fire and function the way that it's supposed to. That's 3 adjustments. There's hundreds of adjustments that can be done depending on what's misaligned and what you need to treat. So that, in a nutshell, is chiropractic. Questions about anything? Think of one. Somebody start with one. Yes.
Could you like overdo?
You can. So if you're making an adjustment, you're making an adjustment to a vertebra, to a joint that's not moving. You would never make an adjustment to a joint that is moving properly. So technically, you cannot over-adjust. However, I'll take the YouTube examples where they're moving everything, things that may not need to be moved. The difference is specificity. So can you be over-adjusted if you don't need an adjustment to a joint that's already moving? Yes. Properly an adjustment, the definition means that you can. Yeah, that's a great question. Absolutely. Anybody been adjusted? Oh, awesome. That's way more than I expected. That's great. Okay. Things you like about being adjusted, things you didn't like? Just curious.
I have my jaw adjusted.
So this is a very neurologically active joint, the temporomandibular joint. That's interesting because there's not a lot of chiropractors who do that. So that's cool. That's really cool. It helped? Yeah, that's neat. Yeah.
I grind my teeth at night. So.
Very common, yeah. So then, you know, the disc in between there can get worn out and stuck, whereas your jaw popping a lot, and you'll tear that thing up. And chronic pain of the TMJ is not fun. You're young for that too, sure. Anybody else? Any questions? Yes, sure.
You talked about the fascial meds. So if you want to learn more about that, where should I start?
Oh, that's a great question. You know, I learned all my fascial anatomy from Guy Voyer. He is what they call the father of the fascial system. So we would.
He sounds like Yoda.
He is. Look, I hate to talk to him like he's some, you know, like high up God, but like the guy's, he's developed. You can't even imagine. You take the highest person that you know and whatever. It's that guy. You know, it's Einstein of physics, but he's of the body. So he would, I went to lunch with him one day, and he told this story about how he worked at a hospital. First, he was orthopedic surgeon. He was an orthopedist, and he got sick of prescribing medicine, and this is in Europe. And so he said, and he went to osteopathic school. He went to 3 of them. And he was a physical trainer, an athletic trainer. He did that for a while, and then he went to medical school. Then he went to osteopathic school. And European osteopaths are different than American osteopaths. But he said that he was working in a hospital, and when they would do an amputation, he would take the limb home and he would dissect the limb. Because I asked him, how many anatomy dissections have you done? And he goes, well, I cannot count. I'm like, well, why not? Like, give me an idea. He's like, well, I would take things from the hospital and dissect them. This guy's nuts. He goes, yeah, I took this, one time I would take the skull, I put them in an ant pile, it would eat all the tissue off so I could study the inside. You know, and then when he talks about it, he's like, okay, the crista galli, which is the front part, connects into the dura of the false cerebelli, which he's just like.
Hey, look, we have the anatomist table, you guys don't need to get body parts, just let me know when you want to use it.
Well, and what's interesting is that, you know, when I went to school and we did the cadaver, you know what we did with the fascia? We call it cat food. You threw it off to the side. Nobody ever showed you that the fascia was something important. You know, the stuff you take off chicken that's over the meat, that's the fascia. The fascia surrounds everything in your entire body. The periosteum is the fascial layer around it. So, or it has a covering on it, that's the fascia. So when you stretch, you don't just stretch a muscle, you stretch a chain of things. Thomas Myers in the like massage world, he's got anatomy trains. That's kind of the it's kind of the global overview, and then you can get super detailed after that. But I would say that's kind of the Bible that most people go by, studying the fascial change in the system. Yeah. And it's becoming more and more popular, and there's dissection courses on it and all kinds of cool stuff. So it really does change your treatment completely once you understand. The fascia is not just this connection, it has receptors in it that give a sense to your brain of where everything is in space also. So it's just, it's the system that was thrown away, all of a sudden is the most important. Yes?
What's one of the coolest cases you treated?
So there was this is a while ago, there was a guy that came in, 33, this is right, I probably just started practicing, I was probably 2 years in, and I took an x-ray of his neck, and your neck should go, you should have a curve that goes forward in the neck. His was completely backwards. I mean, like, we measured in percentage. He was negative 137%. You should have a 40-degree curve. Well, he came in because he had migraine headaches. And these migraine headaches he had every day. He would have to take medication for it. He was depressed because he got so many things. He couldn't work. He couldn't take care of his family. He was tired all the time. They had him on Adderall. He couldn't sleep. They had him on Ambien. He was on Wellbutrin for his brain because he was depressed, dopamine stimulator. And these migraines just took him out. And he goes, I've done everything. I've taken every medication. They just won't go away. My wife, I was treating his wife. So my wife said I had to come in here. I think chiropractic is bull. I don't want to be here, but I'm here and I have to do it for her. So I'm going to do it. So I did his assessment. I could feel how tight his neck was. I took the x-rays, and then, you know, the next day he comes in, I go over his x-rays, and I said, Dwayne, what do you see with your neck? And he was just like, oh, man, you think that could be what's causing my migraines? Absolutely, because when you stretch the spinal cord, when it should be relaxed, when you have a reversal in your neck, which happens after trauma, it stretches the spinal cord, everything lengthens, the blood vessels lengthen, you don't get enough blood flow to the brain, you pull on the brainstem, and it sets up tension lines all the way to the midbrain. So you always feel like you're in a stressed state. So I said, well, Dwayne, we do a corrective program where I adjust you and we help to restore the curve in the neck. Some people it can, some people it can't. We do 90 days of treatment, we take another x-ray, and we see how you're doing. After a second adjustment, his migraines went away. Was the spine back in a position yet? No, but it opened up something, the cerebrospinal fluid flow to the brain, the blood flow to the brain, and so he's like, well, I guess I'm gonna continue doing this. So we got to his post x-ray, perfect curve in his neck, no migraines. He, with the help of his physician, got off all of his medications, went back to work, and the wife said, this is a different husband. Like, he's just, this is amazing. And since I was so early in practice, it just inspired me to be like, okay, everybody needs, your spine is the only one that you have. Like, when are you gonna take care of it? When you're 50 and 60? No, the earlier the better. Because even if he had that with no symptoms, would it be bad? It'd be terrible. He wouldn't even know what it's doing to the internal part of his body, his brain not communicating with everything. So he's one of the coolest cases because he was just so thankful. And then Katrina happened. He ended up moving to Texas. He called me. He said, I need another chiropractor. You got to find me somebody. He's found another chiropractor. And there's hundreds and hundreds of those. He's just one that stands out because it was so early in practice, and it was just such a big deal because all the medication changes and referred a ton of people in. It was just a cool story for that. Yeah. Yes, sir.
In athletes, what are some of the most common problems that they
Depends on what sport. Since sport is so imbalancing at high levels, right? So a pitcher is going to have different problems than a basketball player or a hockey player, right? So a lot of times, let's take golf. A lot of rotation. So if their thoracic spine doesn't have the proper mobility, they tear up their disc.
He plays tennis.
Tennis, okay. So overhead shoulder issues with tennis, of course, right? But a lot of times the shoulder issues are from not being able to rotate or not having the proper core strength or shoulder mobility. So if you don't have the right shoulder mobility, then you bend further back, and then you put more tension on the capsule to get more power, and then you're coming through the whole way, and then you're pulling forward this way. So if you're not doing things to de-rotate or to make sure you have enough rotation in the thoracic spine, make sure you don't have enough shoulder mobility. And I wanted to do the shoulder adjustment, which I won't, but there's an adjustment for the clavicle, the shoulder, and the humerus where we put it back in that way. So a lot of times a tennis player will come in and you'll see this. They're here. And I've got to adjust this way, right? But they need to do exercises to stretch the pec or to strengthen the rhomboid or to make sure that their rotation of the thoracic spine is normalized. So yeah, it can be anything. That's the fun part, is tracing that back. You're kind of like a detective, trying to trace back, okay, what's the cause of the problem? What do they do? I mean, moms have it the hardest, you know, they're carrying babies, they're moving things around, driving. I mean, like, their spines are usually the worst. They're worse than athletes, you know, so yes. Any other questions? So if anybody wants to go, so we'll take one more, then if anybody wants to go, we've got, what, 10 minutes left or so. If you have any other chiropractic questions about school, business, any of that, I'm happy to answer it.
Yeah, what's the difference between an osteopath and a chiropractor?
What was the first part?
What's the difference between an osteopath and a chiropractor?
Yes, okay, so back when chiropractic, so I don't know if you know the story of chiropractic, but D.D. Palmer was a magnetic healer. Back in the late 1800s, 1895, magnetic healers put their hands on human bodies. They were natural healers, basically, but they felt the tone of the body. So D.D. Palmer said that life is tone, and a normal tone is normal health. So he had a janitor that came in and said, you know, he said, well, the janitor was deaf, but he said, how did you lose your hearing? He could hear a little bit close. How did you lose your hearing? He said, well, I was stooped down one day and I heard a big pop and I couldn't hear from that day. So he said, well, get down on the bench. And he felt his spine. He felt, and you know, there's a story written out about this. He felt his neck and he said he felt one of the bones out of their normal juxtaposition with the other one, and it was hot and swollen. It was a facet joint. It was, the bone was misaligned. And he said, so he put Harvey Lillard on a table and he, quote unquote, racked the vertebra back into its proper juxtaposition. Immediately, Harvey Lillard could hear the train 2 miles away with the horn in the background. So he got his hearing back from an adjustment. And there's been speculation on how that affected the lobes of the brain with blood flow and all kinds of things. But D.D. Palmer thought that he had discovered the cure for deafness. So he had a bunch of deaf people come in and he analyzed them, and you know, he had this new thing where he was going to work with the nervous system by hand, chiro by hand, practic, application by hand. Well, none of the deaf people got their hearing back. He said, all right, back to the drawing board. But then they started to come back and say they were noticing all kinds of different health changes. My digestion's better. Hey, my headaches went away. My heart functions better. At the same time, so D.D. Palmer gravitated towards the nervous system is the primary governor of health and function. Osteopathy was developed by A.T. Still. He said that the blood flow is the primary modulator of the health of the tissue. So these two professions developed in tandem over time. A.T. Still, Littlejohn, then you had D.D. Palmer. His son, B.J. Palmer, was brilliant, wrote all kinds of books. Chiropractic wouldn't be around if it weren't for him. He was the one that said, hey, we're not treating disease by adjusting the spine, we're improving function. So it's a separate and distinct healthcare profession that's non-allopathic, because, you know, allopathic medicine, the Rockefellers, they were chemical health, right? Remember, back in 1895, they were still bloodletting. So think about the healing arts at that time, and they developed concurrently. Osteopaths in Europe stayed with that same philosophy of blood flow and fascial connections and dura, and they did mostly soft tissue and long lever adjustments, whereas chiropractic was short lever adjustments to affect the nervous system. So one was blood flow, one was the nervous system. And then in the United States, osteopathy got absorbed by medicine. Now they have hospital privileges, some are anesthesiologists. You would know no difference between an osteopath in the United States and a medical doctor. But in Europe, they're completely different. Now, Guy complains all the time that the level of schooling of osteopaths in Europe has gone down the trash, into the trash, and the same thing really has happened in chiropractic school in the United States. There's about 7 of them, 2 of them are good, the rest of them are not so good. They're very medical, they don't really even adjust, they don't understand the principles of chiropractic. The other 2 that are still around, you still have to pass your boards, they're very medical. You have to know how to diagnose cancer, you have to know how to you know, you have to know, if you look at an x-ray and there's cancer, you have to know the appropriate referral. So again, 80% is like what not to do, you've got all the laws. So once you get out of school, then you start to learn all the cool stuff again. They kind of give you the baseline of everything. So that's a long story about the two differences between osteopaths and chiropractors. Then they're different in Europe and the United States, osteopaths are. All right, so